to characterize the fundus lesions, fundus photography. If you want to focus on the lesions in the peripheral or post-equatorial retina, it's the ultraviolet field. Is the disease active and you want to monitor? Autofluorescence, many a times, may be combined with the OCT. If you are looking at a case of retinal vasculitis and want to look at the leakage, new vascularization, capillary non-perfusion, then it is fluorescein angiography, preferably ultraviolet field. If you are not sure what you are looking clinically and you want to study the choroid for granulomas or something, ICG is there. If you want to localize the lesion, you want to study some of the biomarkers, OCT. And finally, if you're looking at choroidal new vascularization as a complication you want to delineate, there comes angio-OCT. Now, choosing the right imaging modality is very important. We generally look at our retina colleagues, and whatever our retina people tell us, we start following it blindly without even understanding whether that will be applicable in the context of uveitis or not. Now, here is a picture. Multimodal imaging, we do have pseudocolor. Now, Heidelberg doesn't even have the true colors. So this is a 40-year-old man, decreased vision. So, you know, he was being treated for TB, and you look at the picture, it looks normal. You know, you don't see anything in the picture because it's a MCI picture. It's not a true color picture. And here I will show you the comparison. This is multicolor imaging where it looks normal, and the moment you go to true colors, you realize there is a granuloma sitting there which you can see on autofluorescence, but you miss out on certain other imaging modalities. Not only the presence, the disease activity. Look at the first picture where the black arrows are. Is it active edge of serpiginous choroiditis? Nobody can say that the disease is active looking at MCI, whereas when you look at the true color pictures, you do realize there is an active disease which is yellow in color. So this is what is important, that multicolor confocal scanning laser ophthalmoscopic images, which we published in the journal Retina, may not actually give you the clear picture of the way we are used to of looking at uveitis, because to us, yellow means active. To us, green doesn't mean active. So we have to relearn. So you should be very mindful of the imaging modality being used. When we come to the lesions like acute retinal necrosis and you want to follow up this patient, then the ultraviolet field is the answer. For example, we see here, this is the picture taken at baseline. Then you see 3 days later, you can see that some of these lesions which you are seeing here are disappearing here. You can monitor, add therapy, and subsequently patient develop tubular necrosis. We have to struggle, but you can actually see the edge becoming discrete, the new lesions not coming, and finally the response to therapy. So this is possible only with the ultraviolet field. Fundus autofluorescence is very useful for monitoring disease activity, especially in patients with serpiginous-like choroiditis, which is very commonly seen in India. And here you see the hyper are active, and as they start responding, they will become less hyper. You can obviously do ICG to show you more extent of the disease, but you cannot repeat ICG to monitor the disease. So you have to monitor it on a non-invasive device like autofluorescence. You keep on seeing new lesions appearing, you do the interventions, and finally you see the response to therapy. If it is a case of retinal vasculitis and you want to look at the peripheral leak, capillary non-perfusion like this one, you have to rely on your fluorescein angiography, the traditional ones where you will see the leakage, you will see the capillary non-perfusion, or the new vessels which might be coming up. Now, looking for the choroidal granuloma, for example, this is the patient. It was actually a case of sympathetic ophthalmia where we truly struggled a lot to make the diagnosis. He kept on developing vascular occlusions. There was diffuse leak on fluorescein till the time you see ICG. You look at the ICG, these small choroidal granulomas studded in the stroma all over. There is sympathetic ophthalmia is the kind of the diagnosis. You just look at it and you say, well, this is sympathetic ophthalmia. Imaging biomarkers, if you want to study OCT, is a very good image. And I mentioned previously TB. This is a large TB granuloma. You will see vascularity on the TB granuloma, which is very important. If ever there is a confusion between TB and sarcoid granuloma, the top panel is TB. TB granulomas are solitary, lobulated, intense yellow, overlying hemorrhages, new vascularization, and outer retina typically shows these changes. Sarcoid granuloma in the bottom are very small, discrete, multiple. They are located in the stroma, so you don't see changes in the outer retina or so much of a bump. And my last was that sometimes patient comes to you, for example, this one is patient actually from this particular city, Kolkata. Now, she has been managed for uveitis, posterior uveitis serpiginous, doing well, but she's a techie. And she complains of recent onset metamorphopsia, for which she was advised to take a second course of ATT with immunosuppression. So this was the time when we saw her. When you do angiography, there is so much happening, you can't really pinpoint exactly the changes. But if you do your OCT angio, you see there is a new vascular network which is lying there, and that might be the reason why she is complaining. So after discussing with her, I wasn't honestly very sure whether to inject, but we just injected and the configuration of these new vessels changed and her vision improved. We still waited, and without injection, she started deteriorating again. So there may be very fine new vascularization beneath the scars, which are responsible for the symptoms of the patient, and it's not always a recurrence. So please, if the disease does not appear like recurrence, don't start on steroids or repeating the treatment again and again, because that might not be true. And this is just, we have published that these new vessels which they develop in TB are actually type 1 kind of choroidal new vascularization. You may not see fluid, but they will be lurking behind what we call as, very low-lying PED. So to conclude, you have to use these very judiciously. I think TB uveitis, I might have copied it from some other talk, but overall in uveitis. And the imaging modality should be decided depending on what is the phenotype, what is the stage of the disease, and what is the information that you are getting. Always ask yourself a question that this is the answer I want, decide the imaging modality, and when the result of that imaging comes, that answer has to come. It should not be just a frivolous imaging that you want to do everything for everybody because you heard in meetings people talking about, Muller cells or hyelocytes or something. They are good for understanding the disease, the pathogenesis, the newer molecules, but they are not to be extrapolated into your clinical practice day to day. So imaging modality may change from patient to patient. For example, at baseline, you may want to do ICG because you want to see the extent of the disease. But while you are following up the patient, you can follow up the same patient on autofluorescence. And subsequently, when there is cystoid macular edema, you do OCT. And many years later, when there is new vascularization, you look at it and decide what I want to do now. So that's all for today. Thank you very much for giving me the opportunity.
So the next talk is by Dr. Francisco Picci, an OCT journey from histological to microscopic visualization.
Now I'm scared because I'm going to talk about hyelocytes. Hey, I have 10 minutes. 10 minutes. It's okay, I'm kidding. Oops. Can I go? Yeah. Okay, so this is Google Maps of my hometown. You can see I was born in Italy, in the north of Italy, but you cannot see a lot. So this is how OCT started for all of us in uveitis. You could detect most of the complication of uveitis, CME and its treatment, choroidal neovascularization, and its improvement with the treatment. But it's like driving a Ferrari in a parking lot. So we were not using OCT at its full potential. Now zooming in, you know I was born around that area. You have some telltale cities here, some autoroots, so you could find out where I was born. And this is where we took OCT next. We were looking for biomarkers of our disease. So in multifocal choroiditis, for example, with OCT, you can find some telltale signs that are telling you this could be multifocal choroiditis. For example, this hyperreflective material breaking through the RPE. And behind the material which is breaking through the RPE, there's usually this cone of hypertransmission. And when the material hasn't yet broken through the RPE, the cone is still there. Same thing happens, for example, in AMPI. We heard about AMPI, and OCT is giving them some sign. Choriocapillaris ischemia, this alteration of the RPE, and the edema of the outer nuclear layers. And of course, we heard a lot about all the OCT signs of VKH, this choroid thickness, loss of the vasculature, and the ondulation. Now you zoom in, you know I was born in Bologna. Now you get a clearer idea. You can see my hometown. So we are going smaller and smaller with OCT. And there's a lot of papers published out that look at OCT compared with this histology and show how it corresponds very, very well. So for example, in viral retinitis, OCT shows a disruption of the retina with the lacunae, and this is reflected in histology. There's a full thickness retinitis reflected in histology as well. When you deal with toxo, we heard a beautiful talk on toxoplasmosis. On OCT, you have both the full thickness retinitis and the choroidal infiltration. So this could be probably granulomatous and secondary, but so this is probably a retinochoroiditis. Again, comparing OCT and histology in toxo, here you have your retinitis, full thickness, and here you have your choroidal granulomatous inflammation, so the choroid is affected as well. In TB or sarcoid granulomas, look how EDI corresponds very, very well to histology. You have, with EDI, you have choroidal granulomas that can be distinguished because of this halo behind. In every choroidal granuloma is hypo and has this hyper halo behind it. So it's difficult, it's easy to distinguish it from normal blood vessels of the choroid. We go to Candida, and again, there's a perfect correspondence between histology and the OCT. So here you have the Candida trying to go through the retina into the vitreous, because Candida does this. Whether it comes from the choroid or from the retina doesn't matter. It always tries to go towards the vitreous. Now, this is my neighborhood. Now you're seeing stuff in Google Maps that you can actually see with your own eyes. And that's the next step of OCT. We are seeing stuff that we can see with our own eyes and a slit lamp. So we've been using OCT, for example, to visualize keratic precipitates. Keratic precipitates are not part of sun classification, but it's something we look at all the time. And if we use anterior segment of CT, we are actually able to define them, isolate them, and create an en face map of the keratic precipitates. And you can see, for example, in this patient, you see the keratic precipitate as baseline and all these dots on the en face OCT, and you see how they improve with treatment, both clinically and on OCT. You can also look at the cells in the anterior chamber. Now, this has been going on for some time. It was studied first in Kola Institute, then by the Milan group. So all these little dots that we see clinically, they can be highlighted also on OCT. And they have different size, so we could technically distinguish them based on their size. This can be polymorphous nucleates, this could be mononuclear cells. We recently, it's not published out yet, but this is courtesy of Alessandro Invernizzi, so they are looking at, through swept source OCT, at cells, anterior vitreous cells, which again, not highlighted by the sun, but the MUST has a clinical scale for those, and using image J, they are able to count them and prove that there's an improvement. This is their uveitis group. You see all these studded cells behind the lens, and these are the control patient, where there are a couple of cells, they may be just vitreous debris because they are usually bigger. And finally, this was started by Alistair ages ago, looking at the haze of the vitreous based on OCT. But we are actually able to look also at vitreous cells. We published recently on American Journal that on OCT we can actually isolate all these cells and actually measure the flare. So we went from just looking at the bubble of fluid to looking at very, very small cells. Now, this one is my terrace. So it's something that you are zooming in a lot. So this is the future of OCT. Dr. Vishali pointed it out. It's not something you're gonna apply in your clinic, but it's something useful for research. This is a macrophage. Macrophage and microglia, they're part of your retina. They stay inside the retina, and then they go to the surface of the retina. Now, there's three types of microglia. The resident one that grab the antigens and they present it, or macrophages as well that grab stuff from outside. You got your halocytes, that are keeping the transparency of the vitreous, and you have leukocytes, which are very important for us because if you have inflammation in the eye, the leukocytes are coming. Now, this is again the same macrophage that I showed you, and it's done with the electron microscopy. And this is a representation of the macrophages on the retina. You can see them moving around. You can see their little pseudopodic arm grabbing here and there, trying to clean your retina. Now, how was this picture taken? Was it taken with some fancy electron microscopy thingy? No, it was simply taken with an OCT. In particular, OCTA and unfast OCT. Now, these are all parameters of OCTA that we don't really use in clinic, but in the medical retina people that, as Dr. Vishali said, they're driving our research, they looked at these macrophages-like cells for some time. So how do they do it? Well, Vas was the first one that said that if you do one OCTA, it looks like this, but if you average 6, it looks much better, so you have a much better resolution. And same thing applies for the OCTA, but also for the unfast that you have next to it. And the unfast is usually of the inner retina, but if you just move the scan above, this is what you get. So all these little dots are the macrophages of your retina. So how do we know that these are actually macrophages? These are actually moving. So you have some uveitis, especially who stood in front of a machine for 8 hours, and you can see all my macrophages here moving. If you superimpose the OCTA, you see that they stay around the blood vessel. They scan an area of retina. They don't move too far. They make sure that area of retina is fine and clean. And if you zoom into one particular area, you can see how they're moving, the pseudopodic movement. This is my other eye. Again, here you can see that they are moving, but they don't roam around too much, and you can see their movement here with the little pseudopodic arms moving. So why is it useful? Because in uveitis, like this MS patient, you have a lot of macrophages at baseline when there's a lot of inflammation, and they decrease when the inflammation is less. Same for this idiopathic panuveitis. Lots of these macrophages in the beginning, and they decrease with time. Now, I thank you very much for your attention, and I want to highlight what Dr. Vishali said. The last part is for our research, is to better understand diseases and have better biomarkers in the future. Thank you very much.
So the next talk is by Dr. Anup Kelgaonkar, and he's discussing My Eye or AI, the future of imaging.
At the outset, I want to thank AIOS, and it's a very difficult topic, trying to plan a trajectory of a newborn kid around the town. And my eye versus AI, I don't think it's really a topic of debate, but possibly a marriage between the two would be what we would have in the future. But let me start with what the AI is there for us at present. Most of the AI models that we have at present are LLM models. ChatGPT is what comes to mind. Google Bard, which is now Gemini. Twitter, the former Twitter, has its own model. Cloud is there, and Wisdom AI. I put one of my papers in cloud.ai, and it nicely summarizes the things for you. So if you put the paper, you can put it questions, and it would give you answers based on those papers. So churning a very large data would be very easy with this LLM models. Second thing that you can do is the LLM models have an interactive chat. They can decipher the patient symptoms, investigations, and if you put in symptoms, and the ChatGPT generally does a fairly good job to decipher that. It does come with various down points, though. I'll visit one more AI model, which is wisdom.ai, and you can just browse various journals, what the keywords are, what are the areas they have for focus on. I took an example of ocular immunology inflammation here, and it just shows up that what the topics are, probably the most researched topics in this journal or during a particular time period. So the LLM models that we have can and are nowadays used for language, grammar correction, plagiarism checks, sentence constructions are there. The greatest limitation of them are they sometimes hallucinate. And the next models of the LLM do have the image processing capabilities, and they can do and generate image as well as evaluate them. Now, deciphering symptoms and investigations is something that has brought LLM models to the forefront. What people are trying to look up is, can LLM models be integrated into an EMR? And one of the greatest limitations of human brain would be we are unable to focus on years of follow-up, lots of symptoms, lots of medicines, and lots of investigations. And if patient comes up with a particular symptom, I have a headache, and we have to go back to the note, see, is it a drug complication, is it a disease complication, disease process affecting that, and there is where I think the AI could decipher all loads of investigations, multiple symptoms, and the long history that the patient has, and give you a clue on that. So these are probably what LLM models do with. Going on to the later stages where image recognition and machine learning are one of the predominant ones. So AI is the biggest circle that we have, and then machine learning, deep learning, and neural networks. Machine learning was the one thing that was done very oftenly in the sun classification. For example, when they come up with toxoplasma. So day-to-day practice, as we have been seeing in the morning, has been with fundus imaging, OCT, angiography in the uveitis. And can AI interpret these images is a question that we ask ourselves, and this is something as uncharted waters. Is it a boon or bane? Maybe the time would be a good judge of it. The chatbots versus human experts, there are studies predominantly by Dr. Rupesh Agarwal sir, and initial studies have shown that uveitis experts generally outperform the AI models, especially the ChatGPT ones. This was another paper where ophthalmologists excelled over the AI, but the times could change very faster. And there are newer segmentation models where fluid segmentation, trying to interpret the volume of that, trying to look at the macular biomarkers, geographic atrophy AI model, and other AI models are upcoming as the day pass, and they are interpreting the various indices that we see in the retina. one of the another proposed models is patient getting directly exposed to FFA examination by machine. The machine, which is an AI doctor, interprets all the phases, gives a diagnosis, and finally decides laser versus non-laser. One of the papers that translate this, takes this much further, is trying to create angiography images from fundus photographs, and possibly this could be a replacement to routine angiographies that we do. So these images in the first row are fundus photographs. These are the first image is a real venous angiography, and this is a generated venous FFA, and as seen in this paper, the images were comparable, generated by the AI as compared to the actual fundus fluorescein angiography was done. So these are generally the capabilities that AI has at present, and maybe years later they would go on improving. Most of the challenges that we have in uveitis is sometimes the disease has mimickers, it has similar presentations of various diseases, or a rare presentation of a common disease is what matters, and there would be subjective differences in opinions amongst uveitis practitioners, and I think if we let the AI churn these images, that would be one of the way to look at it. Automated diagnosis of ocular toxoplasmosis are the other studies being done in this era. But it is with cons. It can be with a lot of possible cons. One thing is, I have a very interesting example to give. There was an AI model developed to differentiate between fox versus a dog. And this AI model used to perform very nicely. And at the end of the day, it started miscalculating about 1 to 2% of cases as labeling of this fox as dog and dog as fox. So the AI people went in to see what's happening. And it was seen that whenever there is snow, the AI used to say this is a fox. And whenever it was domestic terrain, it used to mark it as a dog. So sometimes we never know what the AI model is actually seeing. Is it actually seeing the area of interest that we want to or not, is a question that we need to ask. Furthermore, the accuracy of this data and data points is something that would still need a study, and my eye, I think, is here to stay. And one few of the very points in favor of that is an ophthalmologist often is needed in especially research limited settings as our country, where we need to first ascertain whether the disease is there or not, if the uveitis is there or not, is this a case of uveitis, and then go for and doing these imaging modalities, which AI would then probably go forward and see. So I think the gray hairs and warm hearts of an ophthalmologist in the clinic are here to stay, though there are few models that say that we go into a room, the AI checks the images and does the OCT and interprets and possibly give to you. The time is there for those things to happen, but I think nothing could match a compassionate and empathetic counseling by probably a gray-haired and warm-hearted ophthalmologist. Thank you.
And the next talk is by Dr. Francisco Picci, and the subject is the art of interpreting images.
Promise it's my last talk. So I just told you in the previous presentation that OCT is basically the Swiss Army knife of an ophthalmologist. We could diagnose stuff just by OCT. Now I'm going to tell you the opposite, basically. So I'll just start by presenting cases. We've heard a couple of beautiful talks on VKH this morning, and we know that subretinal fluid, the presence of a bacillary layer detachment, the loss of choroidal vasculature, the RPE, undulations, they're all signs of VKH. And here they're present, for example, in every scan. Then we heard about the pinpoint leakage in FA, and this is quite typical. Now I'm going to present you 3 cases, and OCT here in all cases is pointing at subretinal fluid, loss of vasculature, maybe bacillary detachment, bacillary and subretinal fluid, loss of vasculature. So is everything here a VKH? Let's see which one is actually a VKH. So, sorry. I'm going to start, for example, with our first patient here. Now, the first patient, you can see straight away in the fundus has some placoid lesion. So at this point, if OCT is not giving you the correct diagnosis, you go for dye testing. In dye test, you see something that blocks early in FA, stains late. So this is quite typical of AMPI, and the ICG is showing us the choroid and chorocapillaris non-perfusion. Moving on to the second patient. Now, in this case, there is a lot of subretinal fluid, and the fundus photo is showing it. Now, we got more pictures here. Now, in the dye test here in ICG, you can see that there are areas of hypoperfusion that are not as much demarcated as the AMPI one that we saw before. And this is a case of posterior scleritis, where, for example, a B scan would tell you the diagnosis. Finally, this patient has a thin layer of subretinal fluid, and by performing our dye test, you can see that there is pinpoint leakage here on FA and hypo spots on ICG. So indeed, this is the case of VKH. What about this other eye? So OCT, as I told you before, is showing you some cells which could be consistent with VKH, the subretinal fluid, the choroidal loss of vascularity, but the patient is 75, and this is unilateral. So 75-year-old patient, what is the most likely diagnosis when you have something unilateral and loss and this particular appearance? Well, you want to know more about this patient. In FAF, you have, this is not the correct term, but you have kind of that leopard spot pattern of hyper, and this is reflected also in FA early, and in late FA there's diffuse staining. And if you look here on your MRI, you got a beautiful mass, and this is a case of choroidal lymphoma. One more. Now, this is an easy one, maybe. Here you have some fibrin between the retina and the RPE. What is the most likely diagnosis? You can see it here, the hot spot growing on FA. So this is a case of central serous chorioretinopathy. Is this case then another case of central serous? You have some fibrin here, you have your beautiful SRF, and it's quite typical, I would say. But if you examine the patient carefully, you can see there is some kind of intermediate uveitis, some kind of vitritis. And looking at the patient, there is leakage all around, and the patient is young, she's female, and she has MS. So this is just subretinal fluid complicating the case of MS, intermediate uveitis. Now, this is a 55-year-old female that has some cells in the anterior segment. And you can see subretinal fluid again. Now, is this subretinal fluid coming from some kind of uveitis, or what is the most likely diagnosis? Now, here the choroid is very thin, so I wouldn't worry about VKH in this case. It could be anything of these cases, but it's actually a retinal detachment that's causing spreading of the photoreceptors, and actually the patient has kind of Matsuo syndrome because the pressure is high. Now, moving on to the outer retina. OCT in the outer retina, I showed you before how AMPI, for example, gives you this hyperreflectivity and edema of the outer nuclear layer. So are all these cases of AMPI? No, these are all cases of different pathologies. And so this is why OCT is great. I love OCT, but we need to analyze better. So let's start with this patient here. You can see the hyperreflectivity, which is affecting the photoreceptors and going into outer nuclear layer. If you do a couple more pictures, what do you see here? You see a case where OCTA is showing us non-perfusion, which corresponds very, very well to the ICG one, and you see the classical early, block, and late stain. So this is the patient improving with treatment, and this is a case of AMPI, which I tend to treat, especially when it's central with steroids. Now, moving on to this second patient, same appearance as before. Photoreceptors are fuzzy and hyper. There's hyper of the outer nuclear layer. It's not in the center, maybe slightly by the side. So let's examine what the patient has. This is pretty typical. I'm not even going to tell you what it is, because it's super easy after seeing all these beautiful pictures, although this beautiful presentation we had before. ICG is showing the non-perfusion. FAF in this case is very useful to diagnose and follow up, as Dr. Vishali showed us, this case of serpiginous choroidopathy. One more case, again, fuzziness of the photoreceptors, fuzziness of the outer nuclear layer. This is all the same appearance on OCT, but if you look clinically, then you can see there's a bleeding, there's a hemorrhage there. So this is probably a case of some kind of occlusion, where infrared is telling us there is some kind of occlusion of the deep vessels inside the retina. This is a case of acute macular neuroretinopathy. What about this one? This one looks quite different. You have your RP, which is bumpy. You have hyperreflective material, which is obscuring the photoreceptors. This patient, you can see straight away, maybe, yes. You can see straight away in the periphery, you can see the classical appearance of a primary vitreoretinal lymphoma with all these lesions shifting. This OCT appearance can be quite typical of a lymphoma. My opinion, humble opinion, is that the lymphoma cells, they come from the choroid. Sometimes they go under the RP and then inside the retina, and sometimes they tend to go all the way to the vitreous. So this is a case of vitreoretinal lymphoma. And is this a case of vitreoretinal lymphoma? When I saw this patient, I said, yes, this really looks like a case of vitreoretinal lymphoma with this hyperreflectivity, and which is between the RP and the photoreceptors. And the patient is actually looking on OCTA, has a kind of non-flow at the level of the choriocapillaris. On autofluorescence, you don't see a lot. Maybe you see a diffuse hyper autofluorescence here. ICG is showing us some hypoperfusion in the center, and what's quite telltale in this patient before getting any test is this plaque of hyperfluorescent in the macula with the edges that are slightly leaking. So these are the hands of the patient, and this is a case of placoid syphilis. And this is the patient actually the 2 days after. So I think, I don't remember who, you presented this morning the case of syphilis, and you have the RP bumps. So the RP bumps, they appear in the placoid syphilis a couple of days after the initial diagnosis before treatment. So these are the correct diagnosis for these OCT, which actually look more or less the same. So another final case, we were talking about mutes. We heard a lot about the granularity of the fovea. Now, these two patients, they look very similar. There is some fuzziness of the photoreceptors here with an RPE mottling, and same here, except that one is mutes, one is retinopathy from Popper. So to me, the second most important test when you have mutes is autofluorescence, except of course when you do fundus photo. Now, this case is typical of mutes. When we saw it present with the dots and spots, which are hyper because the RP is getting more exposed, and this is a typical Popper retinopathy. And I thank you for your attention.
Thank you. That was a wonderful set of talks. I would invite a few questions from the, yeah.
Wonderful talk, Dr. Pichi. I want to ask a research question. You told in previous talk that APMPP has choriocapillaris involvement, and sometimes some cases with CNS small vessels involvement. Now, and you have shown a fractal OCT there. Now, was functional MRI was done in all those cases of CNS involvement in? The
The working diagnosis is that MP is some kind of vasculitis of the small vessels, so it's affecting the small vessels of the brain as well. So in the research paper that was just published, they didn't do any functional MRI.
Okay, my second question is that you see in macular OCT in Parkinson's disease, now just there is a foveal pit is thinner and RNFL changes are there in the, and if you see just the foveal pit which is depressed in Parkinson's disease and some CNS involvement is also there, do the choriocapillary changes, are there any evidence out of it comparative with the?
In Parkinson, Parkinson?
Choriocapillary layer?
I am not sure. I don't know if the others know anything about this, but I'm not sure.
Okay. Thank you.
I have a couple of questions for you. So one of your papers of granuloma, where you described the blood vessels versus smaller granulomas, a backscatter, that paper was based on EDIOCT, which doesn't actually image the CSI, till the CSI. It uses kind of a technique to image that. But when you image the same images with an SSOCT, you don't generally get those scatters. So how do you differentiate on the SSOCT?
So me and Alessandro, we've been fighting a lot about EDI-OCT and the detection of granuloma, because the paper on retina says, yes, with EDI-OCT, if you scan through all these OCT, first of all, the paper on retina was based on comparison between ICG and EDI-OCT. So you're getting an ICG, and then you're scanning one by one and looking at the granulomas, and you see the hyper halo behind it. And then since we were fighting so much, we decided to use OCTA. So OCTA is very reliable in detecting the granulomas. So if you compare ICG and OCTA, we measure them one by one, scanning OCTA at the level of the choroid. There's a perfect correspondence between the void in OCTA and the hypo lesion, which corresponds to a granuloma. So I believe that if you have a good OCTA, you don't have to do an ICG, a serial ICG to monitor the follow-up to the patient. You can get away with one ICG and then follow with OCTA and maybe one ICG at 6 months. Now it's true, SS OCTA doesn't show you this, and especially you can't go around scanning the whole retina with OCT. So that's what prompted us to go from EDI OCT to OCTA.
Yeah, thanks.
How do you differentiate that granuloma of TB from sarcoid on OCT angio? Is there any characteristic features?
So what Dr. Vishali was reporting, it's the paper that Ani led. We just based it on OCT and the feature, the size, but I don't believe you can on OCTA. So in our OCTA paper, we included the granulomas from TB and sarcoid, and this is just my personal impression. There was no difference at all. What OCTA can add is to look for vascularization of the granuloma for sure, but I don't think
you should use OCTA for granulomas, because OCTA is going to give you the layer-wise. It's not going to give you the entire depth. So like Francesco is saying, when you are looking at the choriocapillary disorders, which may be primary due to ischemia, which may be secondary because the underlying granulomas are compressing on them and producing some areas of flow void, it's a great tool. But you can't use it to look at the granulomas. For that, there is OCT.
I was actually very fascinated by the paper you presented on AI reproduction of fluorescein angiography.
Yeah.
So can you just tell us a bit more about the paper?
No, I'm not part of the study group actually. So they imaged fundus photographs basically of the posterior pole, and the AI was asked to, so it was trained with a lot of images. So generally these AI models required round about on an average 5,000 images for a particular disease type. That's the very limitation of those, and only after that you feed that it could generate but I think there are a couple of more papers on similar models, geographic atrophy in AMD, diabetic retinopathy, amongst others.
There is one thing that I was using ChatGPT for whatever, like asking how to do coffee. And then I actually read the amount of water that ChatGPT consumes for every question you ask her, even like the stupidest question. I don't know how many liters, 10 liters of water per answer. So I just stopped. I use it for if it's really important or if I need to.
Really?
Yes.
It's not for fun.
No.
I wasn't aware of it.
So, so my wife actually told me off. So because I was using it for.
So wives are always
yes,
right.
they're always
They
right.
don't try.
So she actually looked it up, and it produces so much heat that to cool it down, they need 10 liters per. I think it's 10. Don't quote me on this, but it's so much water for every answer it produces. So.
Yeah, I have one more question for you. Your studies on halocytes and the MLCs. How much different difficulties you face when there is minimal of a vitreous haze? And I would many of these cases.
So we have a paper out you saw the MLC macrophages like cells decreasing, and we have a paper out. It's under we're replying to reviewers. So we use you base it on the OCT. The OCT parameters. So if you get at least a scan which is 7 out of 10, then yes, you accept it. So it can have a corneal haze, it can have a vitreous haze, the lens can be opaque. All these are taken into consideration when you look at the minimum amount of quality of the OCT you get. So you set it at, it's usually 7 out of 10 for me. So you have to be pretty strict.
Yeah, thanks. I have one question for ma'am. You showed us, ma'am, Heidelberg imaging, the red, green, blue, and how it was inferior, and also the autofluorescence. Do you commonly do infrared autofluorescence and blue autofluorescence? Have a comparison between that? Do you have any particular disease where you would prefer to do an IRF over a BF?
Yeah, I think those diseases are very well described when you are looking, at some of the photoreceptor disorders and few of the white dots. You do prefer infrared. So I was not focusing on that. What I was saying is that many a times, and what is happening in social media is one person puts an image and asks the entire country, what is the diagnosis? And everybody starts typing the diagnosis. It baffles me. Because suppose you have put an image which has been taken on MCI, which is not, that I did, Anirudh did, Kanika did. All of us thought the disease was inactive, and multiple times, whereas the disease was actually active. So my thing is, when you are using an imaging modality, be very mindful of for what purpose are you using it. About the infrared and all, subtle differences, yes, but they are not for the mass diagnosis. They are only to pick up few things in expert hands.
Thank you very much, and we'll leave it to the next panel.
Thank you.